EMS 245 review gastroenterology. In this review, we're going to discuss disorders of the GI system and digestion. GI conditions can become life-threatening because systemic consequences can result from untreated or undertreated disorders of the GI system. To understand the types of disorders that you will be taking care of, you've got to understand the structures and the function of the GI system. It would be a great idea as part of your review to go back and review the anatomy and physiology of the GI system. The GI system can present with a number of signs and symptoms. Oftentimes they mimic other conditions as well. The number of disorders responsible for causing abdominal pain, diarrhea, and nausea is very large. GI disorders account for 246,000 deaths per year and 21.7 million hospitalizations per year. However, most GI disorders are not deadly, but they can present with pain, nausea, vomiting, and in some cases may turn deadly, as in the case where they become septic. Specific GI disorders that we're going to discuss in this lecture include GI bleeding of both the upper GI and the lower GI structures. We're going to briefly touch on certain liver diseases, infectious disorders, ulcerative disorders, irritable bowel syndrome as well. We will also talk about inflammatory bowel disease. Certain disease processes include ulcerative colitis, Crohn's disease, cholecystitis and biliary tract disorders, pancreatitis, appendicitis, and diverticulitis. We'll talk briefly about bowel obstructions, including obstructions of both the small and large bowel, hernias, rectal foreign body obstructions, rectal abscesses, and mesenteric ischemia. So let's start our discussion with GI bleeding. Upper GI bleeding can be defined as bleeding within the GI tract proximal to the ligament of Treitz at the point where the first two sections of the small intestine meet. The 6 major causes of upper GI bleeding include, and this is in descending order of frequency, peptic ulcer disease, gastritis, variceal rupture, Mallory-Weiss tear, esophagitis, and duodenitis. Most cases of GI bleeding are chronic irritations or inflammations that can cause minimal discomfort and minor hemorrhage. Upper GI bleeds may be obvious or subtle, so it's very important that you understand what to look for. Patients may often experience hematemesis or melena. Melena is going to be when it passes through the lower GI tract. Hematemesis may often be bright red if new bleeding, or it may look like coffee grounds if it is old and digested. The stomach does not like to have blood in it, and it will rid the blood from the GI tract. Overall, you would look for signs of bleeding to detect the criticality of the patient. Their general appearance is the best indicator of the severity. May also see when you inspect the abdomen, you may see systemic or symmetric distension or bulging and ecchymosis, which may be present if much blood has been lost into the abdominal cavity. The main focus of your pre-hospital treatment is going to be maintenance of ABCs. Obviously, we're not going to be able to cure the patient, but early recognition to prevent progression of shock or other critical situations is very important. Just to talk briefly about some of the mentioned causes of GI bleed, esophageal varices. An esophageal varix is a swollen vein of the esophagus. This is due to an increase in portal pressure. Damage to the liver typically causes impedance of circulation, causing blood to back up into the left gastric vein and finally into the esophageal veins. Most often, large esophageal rupture is going to be in correlation with chronic alcoholism or ingestion of caustic substances, with consumption of alcohol or chronic alcoholism being the main cause. You may see classic signs of shock, and your care should focus on airway management, IV fluid resuscitation, and rapid transport. Next is peptic ulcers. Peptic ulcers are erosions caused by gastric acid and can occur anywhere in the GI tract and are termed based on the portion of the GI tract affected. Most often, patients will report pain that increases after eating or with a full stomach. Usually no pain at night. Patients with duodenal ulcers have pain at night and on empty stomachs, but there is a difference in a duodenal ulcer and a peptic ulcer, which would be in the stomach lining. NSAIDs, or non-steroidal anti-inflammatories, are a big contributor. Chronic use of these drugs are a big contributor to peptic ulcers. Acid stimulating products and also Helicobacter pylori are also common causes of peptic ulcers. Gastritis is a pre-ulcerative state where the stomach is inflamed but erosions have not yet occurred. Both of these disease processes affect men and women equally, and again have a variety of causes. Ulcers can also be caused by stress related to burns, and these are called curling ulcers. Assessment findings may include pain that could be localized or diffuse, pain relief after coating the GI tract with liquid such as milk. Bouts of nausea and vomiting due to irritation of the mucosa are also common, and oftentimes lying still will help the patient to decrease the pain. Treatment of peptic ulcers depends on the severity of the pain, with the major focus of pre-hospital management is for you to accurately assess the degree of blood loss if there is blood loss, and also prepare to manage any hypotension that is present. You can attempt to do orthostatic vital signs, which is critical in determining fluid needs and transportation packaging issues. You can control vomiting with antiemetics. Antibiotic therapy is going to probably be effective at stopping any new erosion. Of course, this is going to be in hospital treatment, and also acid neutralization and reduction therapies will be used in the hospital as well. Another cause of upper GI bleeding includes Mallory-Weiss syndrome and Borhave syndrome. Mallory-Weiss syndrome is a type of esophageal condition in which severe hemorrhage can occur. The junction between the esophagus and the stomach tears, causing severe bleeding and potentially death. This type of bleeding is not usually associated with alcoholism. The tear that occurs is within the mucosal lining and does not travel entirely through the wall of the esophagus. Mallory-Weiss syndrome occurs in men more often than women and has a mortality rate of as high as 8.6%. This is going to cause a large amount of bleeding that could lead to the possibility of shock. Borhave syndrome is similar to Mallory-Weiss, but it occurs during vomiting. The esophagus tears longitudinally and the tear travels entirely through the wall of the esophagus. This creates a passage for blood, air, and food out of the esophagus and into the mediastinum. This occurs more often than men and presents typically after a large meal that included alcohol consumption. If this condition is not treated within 2 days, mortality is approximately 90%. As with the other diseases, you want to treat symptoms, try to increase patient comfort, and rapid transport. Moving on to lower GI bleeding. This occurs in the GI tract distal to the ligament of Treitz and most frequently occurs in conjunction with chronic disorders and anatomic changes associated with advanced age. Causes of lower GI bleeding can include diverticulosis, colon lesions, rectal lesions, and inflammatory bowel disorders. And we'll talk about those disease processes momentarily. Assessment will be identical to that of the patient with upper GI bleeding, which includes cramping, nausea, vomiting, and changes in stool. May see melanic stool, which usually indicates a slow GI bleed. This is going to be your dark, tarry stool, which indicates digestion of the blood. If bright red blood is noted in the stool, consider significant hemorrhage, or it has occurred in the distal colon. It may also be a sign of a hemorrhoid as well. Also, focus on early signs of shock and treat for shock if you suspect. Manage ABCs, rapid transport. Moving to liver diseases, hepatitis, cirrhosis of the liver, and also hepatic encephalopathy. Hepatitis has many different types of this disease, and they have different causes and have different signs and symptoms. We'll discuss the specifics of hepatitis more in the infectious disease portion, but hepatitis involves any injury to the hepatocytes associated with inflammation or infection. Changes to the liver secondary to hepatocyte injury cause hypertrophy, fatty changes, loss of architecture, and appearance of lesions and spontaneous hemorrhages. Symptoms can range from mild to complete liver failure. One of the common things that is associated with hepatitis is going to be jaundice, or the yellowing of the skin and possibly the eyes. Usually pain in the upper right quadrant, tenderness is reported, which is not relieved by antacids, food, or positioning. Other signs include nausea, vomiting, malaise, photophobia, pharyngitis, and coughing. You're going to see a sick patient with advanced cases of hepatitis. Inspection of the abdomen is typically nonspecific. However, palpation may reveal an enlarged liver. Treatment here is mainly going to be palliative and symptomatic. Cirrhosis of the liver is essentially the beginning stages of liver failure. Early failure of the liver is referred to as cirrhosis. This is the result of damage from infection or inflammation. And the thing to remember about liver disease is that there's very few portions of the body that can operate normally without a functioning liver. Hallmarks of cirrhosis or early liver failure is going to be portal hypertension, coagulation issues, and the inability to detoxify the body. The first clinical stage includes joint aches, weakness, fatigue, nausea and vomiting, anorexia, urticaria, and also itching. As the disease progresses to further damage to the liver, symptoms and signs of the second clinical stage appear as a colic stool, darkening of the urine, jaundice, iteric conjunctiva or yellow eyes, ascites, right upper quadrant abdominal pain, enlarged liver, and dilation of blood vessels on the abdominal surface. Laboratory findings may also reveal abnormal liver functions, aminotransferases or ALT and AST, which are common lab tests, alkaline phosphatase, albumin, and bilirubin are common blood tests used to gauge the liver function. Coagulation studies are often needed to determine the effect of liver failure on coagulation. Pre-hospital care should be supportive, following general management guidelines, which includes focusing on bleeding control and medication administration. It is important to remember to use lower ends of medication dosages because the liver is one of the primary areas where drugs are metabolized, and so the liver's detoxification abilities are impaired in cirrhosis. In-hospital treatment would include supporting of the liver function, and essentially liver transplantation may ultimately be needed. As the functions of the liver continue to diminish, eventually brain function will be impaired. This is called hepatic encephalopathy, and there's several theories as to the underlying cause of brain dysfunction. One of the most supported reasonings here is because of rising ammonia levels, which affect neurons by changing the flow of materials across the semi-permeable membrane of the neuron. Underlying causes other than ammonia issues include diminished cellular energy supplies, change in the blood-brain barrier permeability, and symptoms can range from mild memory loss to coma. Patients may present with attention deficits, inability to concentrate, impaired complex reasoning, disorientation, impaired behavior, incomprehensible speech, bradykinesia, shuffling gait, and tremors. Clinical findings are more important than laboratory results, and obviously we're not going to be getting laboratory results in the field. Opiates, benzos, and psychotropic medications will make the symptoms worse. There's really not any type of medication that you're going to give that's going to help control the neuro issues here. Your treatment, though, is mainly supportive. Ensure that the level of consciousness is not from some other issue, obviously blood glucose levels, trauma, and overdose. Medical history should focus on past infections, renal function, bleeding, constipation. Rapid transport to the hospital after identification of these issues. Ultimately, there's no definitive treatment other than liver transplantation for these patients. GI infectious disorders. GI infection generally occurs when contaminated food is ingested or when GI tract ruptures. According to the CDC, each year approximately 48 million people in the United States get a foodborne type illness. Approximately 3,000 people die. People who have a more difficult time combating infection include those who are immunocompromised, very old, and very young. Specific diseases here would include peritonitis and also gastroenteritis. Now, gastroenteritis can be split into acute and chronic gastroenteritis. In the infectious disorder discussion right now, we're speaking about acute gastroenteritis, which essentially acute gastroenteritis is what we commonly refer to as a stomach bug. It's a family of conditions involving infection with fever, abdominal pain, diarrhea, nausea, and vomiting. Can be caused by several different types of organisms that typically enter the body via the fecal-oral route. Norovirus is often the cause in adults, while the rotavirus is often the cause in children. Majority of patients who die from gastroenteritis are infected with either norovirus or Clostridium difficile. Patients may show symptoms anywhere from several hours to several days after contact, and the disease typically runs its course over 2 or 3 days. Sometimes it may even last several weeks, and that's going to be rough. Signs and symptoms: abdominal cramping, nausea, vomiting, diarrhea, sometimes fever, anorexia. If the patient reports diarrhea, they should be assessed for dehydration, hemodynamic instability, and electrolyte imbalance. Watch for changes in level of consciousness, signs of shock. Management essentially is going to be based off of the condition, the degree of the fluid deficit. Obviously, IVs and fluid boluses for rehydration, antiemetics for nausea. PPE is going to be very important in these situations. Protect yourself from contamination by vomit or stool. And if they are admitted to the hospital, rehydration, control of vomiting and diarrhea, identification of the organism involved, antibiotic therapy if it is a bacterial infection, and stabilization of electrolyte imbalances. To be diagnosed with irritable bowel syndrome, patients must have pain at least 3 days a month for at least 3 months with accompanying changes in bowel habits. At the very definition of IBS, IBS is a condition in which patients have abdominal pain and changes in their bowel habits. The pathology here is unclear, but normal bacteria found within the small bowel may overgrow, causing pain, distension, and changes in bowel habits. Often show the following 3 factors: hypersensitivity of bowel pain receptors, hyperresponsiveness of the bowel smooth muscle, which produces cramping and diarrhea, and psychiatric disorders connected with IBS. Hyperresponsiveness of the bowel can cause areas of spasm, which can stop fecal movement, creating constipation and bloating, or it can cause feces to move too quickly, causing diarrhea. So it's both ends of the spectrum there. Typically begins during childhood and can be triggered by stress and is often associated with eating. Although IBS is a chronic condition, you will typically be called when the patient is having a flare-up of the symptoms. Oftentimes, patients will report abdominal pain or discomfort, diarrhea, steatorrhea, constipation, or bloated feeling. Management is going to be supportive. Analgesia may be needed if pain is severe. Inflammatory bowel disease. It's important to remember that inflammatory bowel diseases cover several different types of disease processes. Ultimately, inflammation is a natural response to injury, and the purpose of inflammation is to help white blood cells in destroying or sealing off an invading agent. A change in vascular permeability and vasodilation causes redness and swelling, which enables the white blood cells to more effectively get to the area of damage. And specifically, inflammation in the GI system can occur at many levels. Localized inflammation with localized signs and symptoms. Patients with hepatitis usually have abdominal pain in the right upper quadrant, and then patients with peritonitis, inflammation of the peritoneum, experience generalized abdominal pain. If the peritonitis is caused by infection, bacteria may move into the bloodstream, which will make the patient become septicemic. Ulcerative colitis is caused by generalized inflammation of the colon. It causes a thinning of the intestinal wall and a weakened dilated rectum and leaves the colon prone to infections by bacteria and bleeding. This most often peaks between the ages of 15 and 25 years and between 55 and 65 years. It's more prevalent in women than in men, and 1 in 6 patients reports a family member also having the disease. Signs and symptoms: gradual onset of bloody diarrhea, discharge of mucus via the rectum, hematochezia, mild to severe abdominal pain, feelings of rectal fullness, joint pain, skin lesions, and infection symptoms. Management is going to be targeted towards a degree of hemodynamic instability, signs of shock with bleeding, and transport. Crohn's disease is similar to ulcerative colitis, but it usually involves the entire GI tract, especially the ileum. The presence of signs and symptoms outside the GI system supports the theory of an autoimmune component behind the disease. Genetics and family history play a role in the disease itself. A series of autoimmune attacks leaves a scarred, narrowed, stiff, and weakened portion of the small intestine, which can cause bowel obstruction. So again, this is a chronic disorder, and most likely, if you're called, it's going to be because of a acute situation. Management should focus on general management guidelines, including volume resuscitation if necessary, and control of nausea and pain. Cholecystitis and biliary tract disorders. Cholecystitis itself is going to be inflammation of the gallbladder, which can lead to pain and discomfort. Combined with biliary tract disorders, the biliary tract disorders involve inflammation of the gallbladder and include cholangitis, cholelithiasis, cholelithiasis, or cholecystitis. Also, acalculous cholecystitis, inflammation of the gallbladder without gallstones present. Gallstones are believed to be caused by increased production of bile or decreased emptying of the gallbladder. And gallbladder inflammation may arise from decreased flow of biliary materials from major trauma, sepsis, sickle cell disease, prolonged fasting. Risk factors include women, Caucasians more likely than African Americans, older people, overweight or obesity, and extreme weight loss. The 5 F's that are related to people with this condition include people that are fair or Caucasian, people that are fat, females within the age of fertility, and 40 to 50. Classic pattern includes 2 to 3 hours after eating a fatty meal, severe upper right quadrant abdominal pain develops. The abdominal pain can be quite severe. In addition to the pain, the patient may demonstrate a positive Murphy sign. To review that, ask the patient to breathe out, take the tips of your fingers and palpate deeply along the intercostal margin of the right upper quadrant. Ask the patient to inhale deeply, and as inspiration continues, the diaphragm will drop and eventually come into contact with the gallbladder. If the patient has cholecystitis, he or she may suddenly stop inspiring because of a sharp increase in pain, which would indicate a positive Murphy sign. Other symptoms include nausea, vomiting, fever, tachycardia, and Charcot-Triad, which is fever, right upper quadrant pain, and jaundice. Pre-hospital management should focus on making the patient comfortable. Pain medications, including opiates, medication for nausea, and IV with fluids. Pancreatitis is inflammation of the pancreas, which occurs when the tube-carrying enzymes produced by the pancreas becomes blocked, leading to autodigestion of the pancreas. Can occur suddenly or over many months, and it may be single or episodic attacks with remissions. Associated with chronic alcohol consumption, gallstones, medication reactions, trauma, cancers, and high triglyceride levels. Signs and symptoms of pancreatitis will include sharp and sometimes severe pain in the epigastric area, pain radiating to the back, nausea, vomiting, fever, tachycardia, hypotension, and muscle spasms, which may be caused by associated hypocalcemia. Internal hemorrhage is a concern. Remember your signs: Cullen sign, which is going to be bruising around the umbilicus, and Gray-Turner sign, which is bruising in the flanks. Higher levels of lipase and amylase, which are enzymes, indicate more severe damage, and your management is going to be directed by general management guidelines. Assess for hemorrhage. Demerol is a better choice for pain management in case of gallstones, but with Demerol you also need to include antiemetic. Appendicitis occurs when fecal or other matter builds up in the appendix, causing pressure increase. Unless treated, the buildup of the pressure will eventually cause the organ to rupture, resulting in peritonitis, sepsis, and death. It's important to remember that you have cases or presentations of appendicitis, which is divided into 3 stages. You've got the early stage, which is going to include peri-umbilical pain, nausea, vomiting, low-grade fever, and loss of appetite. The ripe stage, which is pain in the lower right quadrant, and the lower right quadrant associated with appendicitis is going to be McBurney's point. And then rupture, which includes a decrease in pain because of the decrease in pressure on the walls of the organ. Generalized pain, rebound tenderness, but once it ruptures, then you run a big risk for septicemia. It takes about 48 hours to progress from the early stage to the ripe stage. And if the appendix ruptures, you may see signs of peritonitis, which include Dumphy's sign, which is severe abdominal pain in the right lower quadrant with coughing, or Rovsing's sign, which is pain in the right lower abdominal quadrant upon palpation of the left lower abdominal quadrant. Ultimately, management is going to include pre-hospital assessment for septicemia. Volume resuscitation may not be adequate. You can use norepinephrine if crystalloids are not effective, and pain and anti-nausea medications. To understand diverticulitis, you must know what a diverticulum is. And this is a weak area in the colon that begins to have small outcroppings that turn into pouches. These pockets are called diverticula, which is the plural for diverticulum. The condition of having diverticula is referred to as diverticulosis. When these diverticula become inflamed, it is then called diverticulitis. A diet low in fiber creates more solid stool, and the hard stool increases colon pressure, resulting in bulges in the colonic wall. As feces travels through the colon, some of it may be trapped in these diverticula, causing inflammation and infection, which can cause scarring, adhesions, or a fistula, which is an abnormal connection between the two cavities. Signs and symptoms of diverticulitis include abdominal pain, usually localized on the left lower abdomen. Of note here, diverticulitis is going to be one of the only abdominal disease processes that's going to cause left lower abdominal pain. You may have issues with GYN type disease processes that could cause left lower abdominal pain, but when you're talking about the standard GI disorders, diverticulitis is one of the only ones that can cause that. Also, classic infection signs, constipation or diarrhea. If the adhesions develop, this causes a narrowing of the diameter of the colon, which can result in constipation and bowel obstruction. Your focus is going to be patient comfort. Ensure the patient is getting the appropriate fluids and pain treatment if needed. Also ensure severe infection is not present. Bowel obstruction is a condition in which the intestines are unable to move material through the digestive tract. There's two main reasons: paralysis of the intestines or intestinal lumen diameter compromise. Small bowel obstruction typically is caused by postoperative adhesions. Scarring can constrict the diameter of the intestine or decrease the ability of the intestine to dilate. Other causes could include cancer, Crohn's disease, hernias, or foreign bodies. Patients will often report crampy and intermittent abdominal pain, initially diarrhea, nausea, and vomiting. Of note, the vomiting may actually be feculent or contain fecal matter. Increased pressure, leading to increased peristalsis. Constipation, you may assess hyperactive bowel sounds or hypoactive bowel sounds. Hyperactive bowel sounds are going to be in the early stages of obstruction, and hypoactive are going to be in the later stages of obstruction. Ask the patient if he or she has a history of abdominal surgery. And treatment is mainly supportive with your concern focusing on sepsis, blood pressure, and volume resuscitation, dopamine if needed. Also, this may be a case in which NG tube may be needed to decompress the stomach of any material that may be built up. Antiemetics and IV fluids may also be needed. Large bowel obstruction can be caused by either mechanical obstruction or colon constricture. Ultimately, if a large bowel obstruction is suspected, imaging studies are really the only way to determine the location, the extent of the obstruction. Signs and symptoms are going to be your typical abdominal pain, nausea, vomiting, distended abdomen, absent bowel sounds, peritonitis signs, unexplained weight loss, and management should be the same as for small bowel obstruction. Abdominal hernias essentially are organs or structures that protrude into the adjacent cavity. There's over 1 million hernia repairs done each year in the United States. Four types of hernias in the abdomen include a reducible, which will return to normal location either spontaneously or by manual manipulation. The patient often experiences little discomfort. An incarcerated hernia, in which the organ is trapped in its new location. Common problem in small is bowel obstruction. Strangulated, the intestine is trapped and squeezed, causing a lack of blood supply to the area, which could actually lead to ischemia, and the patient often experiences severe pain and sepsis. And incisional. With incisional, the intestinal contents herniate through the surgical incision, which is very similar to an evisceration. Management is going to focus on supportive measures, including pain management, and closely assess for sepsis. Rectal foreign body obstruction. Obviously, if you have something obstructing the rectum, then it's going to interfere with defecation. Can be introduced from upper GI tract or anal insertion. Management: absolutely under no circumstances should you attempt to remove the object. Pre-hospital management is simply going to be limited to patient comfort. Mesenteric ischemia. This is going to be interruption of the blood supply to the mesentery, which will cause ischemia of the wall of the abdomen. Four main causes: acute arterial embolism, acute arterial thrombosis, profound vasospasm, or a mesenteric venous thrombosis. Typical signs and symptoms include severe abdominal pain with ill-defined location, nausea, vomiting, and diarrhea, possible blood in the stool. In this case, you really need to get a thorough history. Patients require rapid transportation. This is essentially going to lead to what's commonly called as dead gut, and it's very hard to manage these patients. Fluid resuscitation should be initiated in the cases of shock. And if sepsis is the cause of hypotension, use vasopressors to stabilize blood pressure. Analgesics may also be needed. While this is just a quick review of a couple of abdominal emergencies and GI emergencies, there are many more that you should look over and that you should familiarize yourself with. One last thing that I want to mention here is that pain management is very important and vital to the treatment and the care plan of your patient. If this patient is experiencing severe abdominal pain, they need to be treated with whatever type of medication you have. You probably want to refrain from something like Toradol, which is going to be an NSAID in the case of like peptic ulcer or something like that. It is perfectly acceptable to give a patient narcotics in the case of severe abdominal pain, and as a matter of fact, it would be inhumane to not treat their abdominal pain. For the most part, your care for GI disorders is going to include supportive care, and that's going to be pain control, fluid replacement, and transport. This concludes my review of the specific GI disorders.